Hello, everyone, and welcome to today's Healthcare Provider Webinar, a toolbox for navigating young women's metastatic breast cancer. We're pleased to have you join us, especially during this very demanding time in healthcare. My name is Stephanie Washburn, and I'm the Manager of Healthcare Provider Outreach at Living Beyond Breast Cancer. I'm pleased to serve as your moderator for today's program in support of your ongoing care of young women with breast cancer. We've selected today's webinar topic because of its importance to young breast cancer patients and because participants in our most recent healthcare provider webinar indicated an interest in learning more about helping their patients manage treatment and develop coping strategies. Our goals today are to increase participants' knowledge of breast cancer in young women, its risk factors and outcomes, to build knowledge of strategies for providing care to young women with metastatic breast cancer, and to address survivorship priorities in these patients. We will also address self-care for healthcare providers. I'd like to thank our speaker, Dr. Virginia Borges, for sharing her time and expertise. We're very happy that she could join us today. Before moving on to our presentation, I'd like to highlight several LBBC resources. We will be sharing links to these resources by email after the webinar so you can learn more details and share the information with your patients. This webinar is part of LBBC's Young Women's Initiative, which provides resources tailored to meet the specific needs of women diagnosed with breast cancer before age 45. LBBC has been providing programs for young women since we were founded almost 30 years ago. Our Young Women's Initiative began in 2011 when we were awarded a cooperative agreement with the Centers for Disease Control and Prevention to expand and strengthen our programs for young women, and this CDC funding continues today. We now serve over 100,000 young women and their families every year. LBBC has many programs and resources available through the Young Women's Initiative, including a closed Facebook group and a volunteer advocacy program for young women. We'd also like to highlight 2 new resource pages on our website which allow quick access to meaningful information. The first is an information hub for people with newly diagnosed metastatic breast cancer that offers dedicated resources about diagnosis and treatment, coping and relationships, and more. The second is a healthcare provider information hub with information specifically for you, including resources to pass along to your patients. We also have 2 special programs coming up this fall that I'm excited to tell you about. We're pleased to present Wellness and Wisdom, the Living Beyond Breast Cancer Conference, which will take place October 24th to 25th. This virtual event will bring people affected by breast cancer and their caregivers together with leading wellness and medical professionals to share, learn, reflect, and connect. We're also excited to offer Knowledge is Power, Understanding Black Breast Cancer, a 4-part virtual series which will take place in October. The goal of Knowledge is Power is to empower Black people who have been diagnosed with breast cancer and their caregivers with the practical knowledge to get the best care possible while learning how to advocate to decrease the significant health disparities that exist. Healthcare providers are welcome to participate in both programs, and we encourage you to share the information with your patients as well. More details are coming via email following the webinar. Now, let's move on to today's presentation on navigating young women with metastatic breast cancer. In today's format, Dr. Borges will present, and then we will take your questions online or by phone. We are recording the session and will post it in the coming days on lbbc.org, so you'll be able to watch again. We will notify you via email when the recording has been posted. And one last housekeeping note, we'll be emailing you a link to our program evaluation today. Your feedback is really important to us in planning future healthcare provider webinars, and we appreciate you taking the time to complete the evaluation. If you've registered to receive nursing contact hours or social work CEUs for today's program, you're required to participate in the entire live webinar and complete the online evaluation by Wednesday, September 30th. Social workers must also complete a short post-test and score at least 80%. You will then be emailed your continuing education certificate by October 21st. This Nursing Continuing Professional Development activity was approved by the Ohio Nurses Association and accredited approver by the American Nurses Credentialing Centers Commission on Accreditation for 1 contact hour. It was also approved by the National Association of Social Workers for 1 continuing education credit. Our speaker and planning committee members report no conflicts of interest for this continuing education activity. And it's now my pleasure to introduce our expert speaker. Dr. Virginia Borges founded and directs the Young Women's Breast Cancer Clinic at the University of Colorado Comprehensive Cancer Center. The Breast Cancer Clinic addresses the unique issues of young women at diagnosis, through treatment, and beyond. This includes specialized management in pregnancy and breast cancer, family planning after breast cancer treatment, and clinical trials from diagnosis to advanced breast cancer treatment. The Breast Cancer Clinic works with other departments to offer genetic testing, counseling, and research, as well as tailored survivorship care and sexual wellness clinical management. As director of the University of Colorado Breast Cancer Research Program, Dr. Borges oversees the clinical research team. The program works with the Phase 1 and molecular targeted research teams to offer cutting-edge trials for women with advanced breast cancer. Dr. Borges oversees trials on the significant problem of young women's breast cancer, which carries a higher risk for metastatic recurrence and death. Dr. Borges has over 20 years of experience as a translational researcher with expertise in preclinical translational tumor immunology and cancer biology, novel translational research clinical trial design, and epidemiologic outcomes. We're grateful to Dr. Borges for sharing her knowledge about young women's breast cancer and are honored to have her with us today. Dr. Borges, at this time, I'd like to turn the presentation over to you.
Thank you. Welcome, everybody, and I really appreciate your taking your time out of your very busy lives to spend some time talking about what is a topic very near and dear to my heart. And so we're going to cover a few specific objectives today. Before we get into the nuance of the metastatic setting of young women's breast cancer, I'll walk you through just kind of the overarching data as we understand it today of what young women's breast cancer looks like. Then we'll drill down into what the magnitude of the metastatic diagnosis brings to the table, some specific strategies that we can use in doing our best job for taking care of these patients facing metastatic breast cancer, what are survivorship priorities that we need to remember, and then also, importantly, taking care of ourselves as we tackle this very difficult task. I don't have any disclosures related to my presentation today. We're not really going to be talking about a whole lot of specific drugs, although at the end I'll give you one example of a recent breakthrough that I think is a hopeful example as to how we've moved the field forward. I do a lot of clinical trials with all of these companies that you see listed here. Let's start off with the basics. Why is young women's breast cancer a problem? Because many times, and particularly in a lot of the grant reviews I've gotten back over the years, people will question the impact of doing research in young women's breast cancer because they will say it's a rare disease. So the basics tell us that it's not as rare as most people assume. In the United States alone, there's about 27,000 cases diagnosed each year. The number there is the statistics from 2011, but it really hasn't changed much over time. It waffles depending on the overall number of breast cancer cases, but it's about 10 to 13% of all cancers in this country and in most of the global highly developed, wealthy countries around the nation. In the United States, when you look at women who are diagnosed under the age of 45, it looks different than when you look at the incidence of breast cancer in postmenopausal women. So there's actually a slight majority of women who are actually African American who get diagnosed under the age of 45 in comparison to women who are European American or Black versus Caucasian, whichever words you prefer. That's very different. When you look at women who get postmenopausal breast cancer in the U.S., the overwhelming majority are women who are white, and a minority of women are Black. So it's not only not a rare percentage of women getting diagnosed, but a number of women who are Black and getting diagnosed are different, and that can affect different outcomes. It has long been held that the reason why young women's breast cancer does worse is because they simply get more of the worse aggressive forms of breast cancer. And that's not exactly true. While there is an increased percentage of those more aggressive forms, the overall amount of breast cancer diagnosed in these young women is the same sort of invasive ductal carcinoma that's estrogen receptor positive that we see in our older women as well. It is the leading cause of cancer death in the U.S. and worldwide for women aged 15 to 54, and importantly, it is higher than the next 4 cancers combined in this age range. So things like thyroid, lymphoma, melanoma, breast cancer is higher than all 4 of them combined. What you see there is the likelihood of a woman age 30 or a woman age 40 getting diagnosed with breast cancer in the next 10 years, and while those are not high risks, they're not neutral risks either. So part of the message that we're missing in our world and our community is the understanding that this is not a rare disease at all. So if you were with us, did I do that right? Can you guys see the right slide? Typical clinical day? Yeah, I hope so. I clicked the wrong button on my screen. So in our Young Women's Breast Cancer Clinic, this is a typical clinical day. We'll walk in and we will meet a young woman, in this case a 30-year-old, who comes to us having noticed a lump in her breast for the last 3 months. She was sent in for her first ever mammogram. The mammogram wasn't very revealing because she has young, dense breasts. The ultrasound was more confirmatory, demonstrating a 4-centimeter mass. And unfortunately, it looks like there's already a concerning lymph node in the ipsilateral armpit. The core biopsy gives us an invasive ductal carcinoma, high grade. There's evidence of lymphovascular invasion, which we commonly see in younger women. The lymph node is also biopsied and confirmed to have breast cancer as well. It is all 3 markers positive, estrogen, progesterone, and HER2 positive, or a triple positive breast cancer, which is a higher incidence we see in younger women than in older women of having all 3 markers positive. So who is this young lady? She's married. She has a 6-month-old who she nursed for 4 months. That's her first pregnancy and her first child. And she was thinking about maybe moving towards another child over this summer. She's currently an accountant. She has no family history whatsoever. And she's a very typical Coloradan young woman. She exercises. She has a healthy body mass index. She doesn't have any particularly bad habits. And she's here today with her husband and her mother. So where do we start when we look at a patient like this? Well, first off, why is this woman in our office to begin with? Who gets young women's breast cancer? And I've long made the argument that we don't have a clear understanding of all of the risk factors, and that is problem number 1, because when a young woman, 30-year-old smart gal, gets diagnosed with breast cancer, the first thing she'd like to have an answer for is why? Because as I explained to you, she already had some pretty good lifestyle habits. So why on earth did she end up with cancer? So these are the classic risk factors for breast cancer that we've been taught for decades. Obviously, you have a higher risk of getting breast cancer if you are a woman. And as we get older, our risk increases. However, in young women's breast cancer, there's a couple of other features that are a little bit more likely to have a role here, and that is some of the ones that are highlighted in blue on this slide. So there has been some research, particularly out of Roswell Park with some collaborators there, to show that the use of oral contraceptives can cause an increased risk of getting diagnosed with breast cancer. We also know that there is an interaction between having a child and getting diagnosed, which I'll cover in a few moments. In younger women, particularly our young African American women, if they opt to not nurse their child, that actually increases their risk of getting a young onset breast cancer. If a woman has had a prior cancer, such as a lymphoma, and she received radiation that would capture her breast tissue, the ionizing XRT, which is the radiation, can cause a substantial increased risk of her getting diagnosed with breast cancer in the 10 to 15 years after her treatment. So we want to really keep track of our young women who get diagnosed with Hodgkin's as teenagers, get mantle radiation, and then they're coming into adulthood. They have about a 25-fold likelihood of getting breast cancer. And of course, we know that young onset breast cancer is associated with certain inheritable gene mutations that we can test these young women for. However, those gene mutations still show up only about 15 to 20% of the time, when even in a young woman's population, depending on how strong the family history is and where she is on the planet. So the majority of young women who get diagnosed with breast cancer don't really have any of these risks, and that can be quite frustrating for them. What we do know is an underestimated risk and an unappreciated risk for getting breast cancer comes from just what are the life windows that a woman goes through. So in this cartoon here on the slide, what you see is basically a woman's life history. She is born, she reaches sexual maturity, she either does or does not procreate. Eventually, here at the peak, she goes through her change of life into the menopausal years, and then if we are all lucky enough, we get to be the old grandma sitting down in the chair enjoying our late age. And now the graph that I've just put up demonstrates how that interacts with a woman's risk of getting breast cancer, depending on if she has a child and at what age she has that child. So on this graph, the reference point, which is the line marked number 1, is the risk lifetime of a woman who does not ever have a child of getting breast cancer. So that's set as ground zero, if you will. And what you see in this slide is that all women, regardless of how young they are at the time that they have their first child, actually experience a number of years where their risk of getting breast cancer increases. So if you're in the blue line and have your children under 25, the risk is not that much increased, and by about 9 years later, it's crossing over, and having had that prior child is now demonstrating protection against the effect of breast cancer. If you're 25 to 29, you're in the pink line. If you're 30, you're in the yellow line. And if you're over 35 at the age of your first child, you're not on this chart because you're off the top mark. And what we see is that a woman who is older having her children for the first time experiences an extended period of time where she's at an increased risk for getting breast cancer before this crossover effect occurs, and she is protected from that. And what we know is that, this crossover effect in the women who are having their children younger do represent the majority of how women have behaved in the past. And the majority of breast cancer diagnosed in the United States occurs here in this postmenopausal breast cancer range. So for the majority of women who get breast cancer or who are at risk for breast cancer, having had those children previously is protected. So on balance, pregnancy does protect against the risk of breast cancer. However, what is left out of that story is the fact that you have to navigate these postpartum years when you are young and having your children and not get diagnosed with breast cancer to end up in the range where you can then become protected by it if you had your children young enough. And what we see is that women who get diagnosed with these breast cancers under the curve of this increased risk, we call them postpartum breast cancers because they overall represent a little bit of a different biology. And so pregnancy is actually, pregnancy and the completion of a childbirth is actually one of the highest risk factors for getting diagnosed with a young woman's breast cancer. And that's not something that we particularly appreciate. This slide demonstrates what I call tongue-in-cheek my job security. So we know that women are choosing to delay childbearing between the 90s and the early 80s to then the 2014. What you see here is the average age of women having their first child. And there are substantially more women opting to have children over 30 than there are under 20 at this point in time in comparison to decades past. And so what it tells us is that there are an increasing number of women who are making lifestyle choices that could potentially increase their likelihood of getting a young woman's breast cancer. And if you look globally, we are still younger than many of our colleagues worldwide, with the average age of first birth happening around the globe. And so what we expect to see on the basis of these data is that there would be an increase in the likelihood of postpartum breast cancers being diagnosed, and indeed that has been reported from a number of countries, including Sweden and Japan, and there looks to be some similar trends in the United States as well. So back to our patient. We now have a deeper understanding of why she might have gotten this breast cancer in the first place, but now we have to drill down on how we're going to take care of her. What are her unique concerns being 30 years old and walking into our clinic today? Well, one of the most important things, and you'll notice I'm not even getting to the breast cancer yet. There's a couple of things that we have to prioritize thinking about first before we even address the fact that, yes, there's a cancer and, yes, we have to take care of it. So what's unique about her? She's had one child, and she just told you that she was thinking of having child number 2 this summer. So that immediately has to come to the forefront of our mind, and what are we going to do for her? So it brings us right to the issue of fertility. So a couple of key things to remember in the setting of fertility. If a woman has never been pregnant, we don't know what her fertility status is. So if we're going to have to treat her for breast cancer and she's currently 30 and childbearing is on her radar, we would probably want to send her in to our oncofertility or reproductive specialists to get a sense of her baseline fertility. There is blood work that can be done, ultrasounds of the ovaries to do a follicle count, to get a sense of how fertile is this person looking at the time of their diagnosis, because that can help inform what then that couple may want to decide. We do know that fertility rapidly declines naturally after the age of 35, and so for her, she's only 30, but some of our patients meet us at 36, and we're still wanting to have more children, so then it becomes an even more complicated issue. Thankfully, many of the chemotherapy regimens that we use today, as opposed to 20, 25 years ago when I started off in this business, have less impact on fertility. But again, it's a double-edged sword. There's the woman's natural fertility, which may or may not be okay, and then we're going to add drugs to it, none of which are neutral, but some of which are more harmful than others. So we get into the topic of, can we send this couple for egg harvesting and embryo creation for storage for a more guaranteed future fertility, or is that not really necessary or worth it, depending on where she's at with her cancer, where they're at with their clear desire or unclear desire for further childbearing. Let's say our patient came to the office and she was 30 and she was with her mom and she had not yet met her partner in life. So she doesn't have her sperm of choice, as we call it. So thankfully, in the modern era, it has now become standard that we can freeze down just her eggs or her ovarian tissue, and that will turn into a viable child down the line. That used to be experimental, but in the past, 5 to 10 years, it's moved forward and is now a routine thing that we can offer young women. So even if she doesn't yet know who she might want to create a child with, we can still be comprehensive in evaluating her fertility issues. Importantly, what is on many young couples' minds when they first meet us is the fact that she has one child, she wants to be alive for that child, and she does not want to do something that's going to jeopardize her likelihood of being cured. So we have to emphasize the fact that as far as we know right now, if a woman is treated for her breast cancer comprehensively and she is well, her completing a pregnancy subsequent to that treatment does not increase her breast cancer risk. Most of that data is from retrospective series, including a fantastic one run by our European colleagues, but there is also a prospective trial called the POSITIVE trial, a kind of a pun on a pregnancy test, that's been done internationally, led here in the United States by Ann Partridge at the Farber, and we're actively awaiting results of that, which will prospectively demonstrate some of the safety involved there. But most importantly, for the patient in our office today, right now is a really bad time for her to become pregnant, and we just heard that she was thinking about child number 2, so maybe she's potentially being a little sloppy with her contraception right now. We need to tighten. Fertility needs to be controlled so that we don't end up with anything undesirable occurring that would then complicate her moving forward with her treatment. So to summarize that section, I just want to say that I think we definitely need to understand our risk factors for young women's breast cancer, and we need to be mindful of the fact that it's a very frustrating factor in our young women's lives when they get diagnosed because they were leading a healthy life, and that the fact that a woman who is a young mother at the time of her diagnosis can, have a potentially worse prognosis is what I'm going to cover with you next. And just for fun, the picture here is when we set up our Young Women's Breast Cancer Expo booth at various events locally here in Denver. And the young gentleman helping me in that picture is my son. So one of the things that we've done research on in my group that we've published is the fact that not only do younger mothers have an increased risk of getting breast cancer in the first place, but those breast cancers behave worse. So this graph is a metastasis-free survival curve. So the lower the curve, the more metastases that are occurring. And it's comparing, in the black line, women who had not yet had a child at the time of their diagnosis. In the light blue line, those are women who got started early and were more than 10 years out from having had their last child. In the pink line and the dark blue line, those are women who are younger mothers, and in the dark blue line were within 5 to 10 years of having had a child at the time that they were diagnosed. And what you can see is that there is an increased risk of developing a metastasis if a woman is within those years after having had her last child, about a twofold risk when you look at our overall patient population. When you drill down on some important features, like just looking at women who had stage 1 and stage 2 breast cancer at the time that they were diagnosed, it becomes even more concerning, because then we see our young mothers, women with infants or early elementary school age children up through middle school, have a 3 to 5-fold increased risk of developing metastasis by between 10 and 15 years after their diagnosis. And so that is something that we have to keep in mind when we're then figuring out what to do for women. Even amongst the different subtypes of breast cancer, we see this interaction. So even if a woman is a young mom with an estrogen receptor positive breast cancer, what you see in that dark blue line is that by 10 to 15 years out, she's facing upwards of a 40% risk of recurrence, which looks the same in our estrogen receptor negative group, except they recur faster. So what you can see is that these women will have a high likelihood of recurrence by 5 years, but then that curve kind of goes flatline and we don't see additional recurrences happening. In the estrogen receptor positive group, the recurrences happen over time, sort of consistently all the way out to 10 years. And so this is important when we're talking to our young women about things like their anti-endocrine therapy and how important that is for them to take, because we're trying to fight off these later recurrences as well. So how many of these young women are affected by these more aggressive postpartum breast cancers? In our data set, it's about half of the women that we take care of who will fall into being a postpartum mom with a child up to 10 years of age at home, in comparison to not having a kid, a woman with older children, or being pregnant at diagnosis, which is what PG stands for there. Depending on where you look in the United States, these statistics will look about the same. Some clinics might have a higher percentage, some clinics will have a slightly lower percentage, but that's about ballpark. So half of our young women have this increased risk on the basis of being postpartum or interactions with breast cancer and pregnancy. And so the facts of postpartum breast cancer are that it's far more common than most people think. About 50,000 deaths per year, per decade, if you do the math on how many breast cancer deaths are occurring in the U.S. and backtrack with how many women fit this statistic. It has a poorer prognosis, and it's not all surmised just on the basis of the estrogen receptor status. So lots to be learned there. It is a global problem. These are the global statistics of breast cancer. These specific numbers are from between 2012 and 2017, and they haven't changed a whole lot in the last few years. So while there's about 1.7 breast cancer cases worldwide and a little over 500,000 deaths, there are many more deaths in third world or developing countries than there is in the developed world. And when you look specifically at young women breast cancer statistics, what you can see is that in developed countries, which is the bar graph on your right, the blue is the incidence of young women's breast cancer, and the gray is the mortality. So more women get young women's breast cancer than die from it. Conversely, in lower income countries or third world countries, it's about equal. So in those countries, a young woman's breast cancer diagnosis is more or less akin to a death due to breast cancer for that woman, unfortunately. So a lot of work to be done yet. So now we're going to go back to our patient, and after thinking about all of these issues, we're finally going to talk about the cancer. So she's got a triple positive, locally advanced breast cancer, and we start talking to her about the treatment that she should receive. It would be some chemo plus HER2 targeted agents. She'll have her choice of surgeries. She might use her gene mutation results to decide. She'll need chest wall radiation after surgery because of the involved lymph node, and she's going to be a candidate for hormonal therapy, which in a woman this young with a cancer like that's the best for a combination of ovarian suppression and an aromatase inhibitor, with tamoxifen being an alternative option. And then she'll also have to complete some form of HER2 based or trastuzumab therapy for a year after she finishes her chemo and surgery. So even though she's young, and even though I just outlined to you that she has higher risk on being a young mom, we don't yet know how we should alter her therapy different from what we would do for any other aged patient. So, but all else being equal, she does face worse breast cancer outcomes. So, at a future clinic follow-up, for this patient, maybe it's the staging study that she has 1 week later, or maybe it's 3 years after we've originally treated her and she calls in with a new symptom, or the blood work is off. Either way, there's this miserable moment, and what's missing on the screen, I apologize, is there's supposed to be a slice of a CAT scan there showing a liver metastasis. But this is the moment where then the game really changes for this young woman, her family, because now we know that she has evidence for metastatic breast cancer. And of course, we will biopsy it and prove the point. We will make sure that the tumor has not changed in terms of its being triple positive or anything like that. But now is the moment where we really need to set the stage in terms of how we communicate to her and her family on both what is going to be different, the duration of her medical treatment, how we handle metastatic breast cancer, what are the expectations. And this is where, yes, we have science to help us in terms of understanding what it is we believe we know to be true, or what appears to be true today. But it really is up to us to be the artists in terms of how we present this to our patient so that she can maintain hope and maintain an understanding that she has a life left in front of her. It's not going to be the life she had originally planned, but that it could still be a life and a good life. And this is where we become good doctors taking care, and good practitioners taking care of young women's breast cancer versus not. So what are some of the key ingredients? Where to start and what matters most? So again, if this is a newly diagnosed patient, the last thing we want to do is have her get pregnant at this point in time. And so if we haven't done it already, we need to make sure she has some acceptable form of birth control that does not involve hormones. Ongoing, an IUD is a great solution. Condoms can work if they're used well, but we're also going to be talking to her about taking away her ovarian function as part of her treatment. So the ovarian suppression that we would use could work for that, but we have to make sure that she understands that's not a guarantee contraception, and this needs to be addressed. The other issue is we had been talking to this couple about preservation. The question is just should that communication continue if she's newly diagnosed as stage 4 up front? And it's become something that's become an increasingly challenging issue to think about and figure out for our patients as time goes by, because we do have patients who are living for longer and longer and living well with metastatic breast cancer, particularly amongst some of the subtypes of breast cancer, such as the HER2 positive. I have patients who are alive and well over 10 years out after I told them they had metastatic breast cancer, and they've not had their cancer return. So is it feasible for this couple to still consider preservation? It's important to emphasize that we would not want her to carry the pregnancy because she'd have to be off treatment, and the pregnancy could potentially stimulate the underlying cancer. So we would not consider that medically safe, but they could create embryos before she gets started on her treatment and go forward at some point in the time with a surrogate. So it comes down to very nuanced conversations of what is the priority for this couple. They may or may not want to have another child, a sibling for the child they currently have. They might not want to deal with any of that right now. It could be a much too overwhelming conversation, but it is no longer okay to not even discuss it. And again, it depends a little bit on the biologic subtype of the breast cancer. If she was showing up with metastatic disease from triple-negative breast cancer, well, that's a form of breast cancer where we have a much lower ability to keep those patients well for many years into the future, and it is the much more uncommon patient in which we experience a long-term period where they have no evidence of disease in their body, or are on therapies that could be considered interruptible. So, I think you should have this conversation with all women who end up in this circumstance, but it has to be nuanced on the basis of what is the reality of the disease that we're also going to have to be co-managing and co-fighting. I have had patients who, despite my best advice to not do so, have opted to become pregnant and carry a child to term with metastatic breast cancer, and that has caused a lot of gray hairs in my life. And so, you have to tackle that head on in terms of where is this woman in her treatment? If she chose to do that, would there be any reasonable way that you could potentially treat her during that pregnancy? And just really hopefully emphasize that that is something that we would not want them to do and get them to engage in that. And, if they end up doing it anyway and you're in that situation, feel free to call me. It's always a shared difficulty. So the other thing is this patient came to us with a husband and a mother in the room, so she has some levels of support and resources, but we also end up with those patients who have a child at home and nobody in the room. And so we have to really figure out what is going to be the things that are going to help this woman get through as she gets started on her treatment and get her in early and comprehensively with therapists, with social workers, with looking for grants and opportunities to share the financial burden that is going to become a very clear reality in this woman's life as she navigates her treatment. Again, tumor is number 4 on the list. Yes, she has to start on treatment, and in her case, depending on the exact situation, much of what I outlined will get modified, and she may or may not get treated with all of the multimodality options we have. The image I was going to show you would have had one liver lesion, and so this patient was going to specifically fall into a category of what we call oligometastatic disease. These are women in whom we often still take a full court press aggressive approach, and we go after that liver lesion with perhaps some radiation or surgery in addition to the systemic therapy. And these are women who can live for a very long time. I have women who were in their 30s and 40s at diagnosis with stage 4 breast cancer, oligometastatic, treated aggressively, who have now been alive and doing well over 10 years later. It doesn't work for all of them. Sometimes we try this and the cancer recurs despite aggressive treatment. Let's say I had chosen to show you a CAT scan where there were 5 or 6 lesions on that liver, or liver lesions, bone lesions, maybe a couple of spots in the lungs. That's a more advanced metastatic presentation that's not going to be amenable to an aggressive approach like this, so then we really focus on the systemic therapy. Don't go after the local treatment to the breast or lymph nodes in the armpit unless there's some impending reason of problem that's going to get caused there to do it. And all of this matters because it has a huge thing to do with the differences in treatment and outcomes. And the number one thing on this young woman's mind is, am I going to die and when? And so for some subtypes of breast cancer, the field's dramatically changed, so much so that I can no longer promise one of our young women when she might die. And I realize that's a very weird way of putting it, but let's face it, 20 years ago or so when I began my career, I could pretty accurately predict the limited lifespan that all of my patients were going to experience. And while I would never have put a hard number on it, the range I would have picked, which at that point in time might have been 2 to 4 years if we were lucky, would have been accurate. And now, particularly for some of our patients with estrogen receptor positive disease, HER2 positive in particular, but also some with HER2 negative breast cancer or ER negative HER2 positive, we are having dramatic long-term results for many of our patients such that they can live multiple years into the future. These women are young, so I don't think it's honest to be talking about possibilities of normal life expectancies yet. But if we can keep them alive 5 or 10 years into the future and living well with their metastatic disease, it gives all the more opportunity for the next scientific advance to come along. So it is not impossible to believe that the next generation of medical oncologists after me may achieve that endpoint for their patients. Again, we still have our patients who have the triple-negative breast cancer, and that is a more sober experience. We have chemotherapy, we have the immunotherapies, we have some evolving new targeted DANCY drugs that are improving our ability to keep these women for longer. But for longer means I am hopeful that I can get to the 5 to 10 year mark for these women, not something where I can be more optimistic or hopeful yet. But again, every year we gain them allows science to catch up and possibly offer them something new. When I started my career, trastuzumab or Herceptin was not yet an FDA-approved drug. We saw women rapidly pass away of these HER2-positive breast cancers that we had just learned to identify. And it was a very grim experience. And now within the span of one career, and I'm not that old, I'm only 52, it's markedly changed to where now this is something we have a good handle on and can really look at things in a different light. So, it is not Pollyanna or overly optimistic to think that this can't yet happen for our women who are facing more difficult breast cancer. So again, I see a lot of women when they get diagnosed with metastatic breast cancer, they're given the dreaded statement, go get your affairs in order. All of us should have our affairs in order because we don't know what's going to happen the next time we get on the highway or step into our shower, but that's not what you want to say to a young woman newly facing metastatic breast cancer. You need to speak to her in ways that inspire hope, but yet make it realistic that she's going to be on chronic treatment. There will be management for this. Our young woman with a few liver mets or one liver met, she's not in any imminent life-threatening danger from her cancer, and she needs to hear that. She needs to hear that she's going to be on chronic treatment, but it is not something that she's imminently dying of. So then the other thing that we all have to tackle with our patients, whether they have metastatic disease or not, but certainly when they have metastatic disease, is how you manage Dr. Google. And I don't mean to pick on Google, pick your search engine of choice, but we all know that the internet is both a blessing and a boon to the modern world. The internet lets us have this conversation this morning, but it also allows our patients at 2 o'clock in the morning when they can't sleep because of the fear of the diagnosis that they have just had to be on the internet and looking at information, some of which is great and some of which is not. So I like to manage it prospectively. One of the first things I do is to give all of them the Living Beyond Breast Cancer website and tell them there are places they are allowed to go and places they are not allowed to go on the internet in order to get proper information. And I talk with them about the concepts of pseudoscience and things that are kind of right but then get turned around and put into advice given to people newly diagnosed with all forms of cancer, especially breast cancer. That is, it's not exactly wrong, but it's not exactly right. And so our patients end up with all sorts of well-meaning but difficult advice from friends and loved ones and family members and their own searches that have them absolutely spinning over what do they eat, how much do they exercise, should they take this supplement or that, should they accept Western medicine, or are we all a bunch of pharma-paid nefarious creatures who are only out to make money and aren't giving them the treatment that could actually cure them. So it spans a big rainbow of information and misinformation out there. My approach to this is to give my patients the freedom to understand that they have the opportunity and right to look at all of this information, but I am meant to be their main backstop, their main resource, so that I don't tell them to not do this because that's, not going to work, but I encourage them to go to good websites to gain information, and I ask them to be careful about where they're looking. I say, look, if it sounds too good to be true, it might be. And if you're looking on a website where, yes, they're promising you a cure for this tomorrow, but they also are not going to accept your insurance, and they're going to take a lot of money from you, and the people who are offering you this cure are going to make a big direct profit off of what they're trying to sell you. You need to think about that carefully, because there are a lot of people out there who really believe in what they're saying, and they're very honest in wanting to help folks. But then there's also people who aren't, and we have to, on some level, serve a bit of a protective role in guiding our patients. The other thing that I think is important to embrace as care providers is understanding self-determination. So at the end of the day, if you're like me in Western medicine, we aim to practice evidence-based medicine. There's certain rules we all follow to say something is good enough to offer it to a patient versus something is still experimental versus something has been proven to be not useful. But our patients have the right to go do what they feel they need to do with their lives, and sometimes that might be simply to follow our recommendations, but that's rare. Most often our patients will dominantly follow our recommendations, but also be doing something in conjunction with what we're recommending because it's their part of the control. So what I say to my patients is, look, I know 100% of you are doing something that I haven't recommended to you, but what I want is that at least 90% of you are telling me about it, because if I know what somebody else is taking, I can avoid mishaps. I can avoid drug-drug interactions. I can avoid them taking things that could actually be bad for some reason. And so I just ask them to show me and then walk through that. Now, the problem is that adds to our burden of care to our patients. We are accepting the fact that they're going to bring us this information. It's going to be the same old stuff we might have seen 100 times before, or maybe one of our patients will find something new that's about to become the latest trend in the supplement world, because based on my year of practice, I could predict for you what my patients were going to bring to the table as to what was in fashion in that realm. And so you just have to kind of deal with it kindly and gently. They are looking for a better answer than we have given them because we have given them the truth, and the truth sucks. We cannot take this disease away from them in a way that allows them to go forward with the life that they thought they were going to have. And so we have to just honor that and recognize that and be their partner in helping them to guide what they feel is best for them. It's a challenge. My people who work with me hear me complain about this plenty, but I try and stay open-minded and meet my patients where they are in needing this. Now, we also have to sometimes take a firmer stance. If our patients are truly going in the direction of doing something dangerous, we just have to tell them that. The last bullet point on this slide I want to cover is the concept of leave no trace oncology. So one of the things that we get into in the setting of metastatic breast cancer is the fact that treatment is chronic. And so for many of our patients, we start them off on combinations of chemotherapy, and those chemotherapies can have side effects that are cumulative. Well, when you're treating someone with metastatic disease, you're going to be treating them for the rest of their life. And so you want to try and minimize the things that you are going to do to them that are going to cause long-standing hardship for them and make their later years of living with metastatic breast cancer more difficult. So the number one thing that I see that comes to my mind when I put the statements on the slide is the concept of neuropathy. So many of our patients had chemotherapy in the adjuvant setting, and now they're facing metastatic disease, and we are giving them drugs that cause an increased likelihood of them getting neuropathy into their future. And so since no amount of any drug that causes neuropathy is going to cure them of this breast cancer, we have to be incredibly careful about the fact that we titrate the drug to the point where they are having neuropathy but not getting such neuropathy that they then end up with a permanent disability that can leave them having difficulties with walking. Because there's no point in that. We have many drugs that we can use to treat breast cancer. We can modify the doses. There are supplements or medications that we can offer them to co-manage this. And I get frustrated when I see patients where they've just been pounded with chemotherapy to the point that they can't feel their feet, and now they're going to be living with that for the rest of their lives while they also have to deal with the other problems that metastatic breast cancer can cause. And so while that's true also of the adjuvant setting, we don't want to cause permanent disability. I see it more often forgotten in the metastatic setting where people get kind of on a little bit of a ongoing treatment, and the treatment is working, but we have to pay careful attention to the side effects that can become cumulative. This is true also of chemo brain and cognitive functioning. It's true of fatigue, which patients don't often like to tell us about unless we really drill down on how they're feeling, particularly younger women, and manage that. The other big issue of, sort of leave no trace oncology specific to young women's breast cancer is we often, I think, shy away from or forget to address sexual functioning in our patients with metastatic breast cancer. And the reality is for them to be living for years with their metastatic disease, if we can afford them a healthful body that can still engage in whatever form of sexual functioning they choose, that is best serving them. So we cannot forget in our young women who have metastatic breast cancer to ask about sex. Is their vagina dry? Are they able to have successful intercourse if that's what they're choosing to do? And what does that look like? And we also have to remember to refer them to things like a sexual wellness clinic or an OBGYN, or if you're comfortable managing some of their vaginal mechanical issues with dryness and whatever your practice patterns are, whether you use the intravaginal estrogens or not. I tend to, because I don't see them as being a problem with controlling the overlying cancer when you're using things that are only contained in the vagina. And I think it's incredibly important to maintain that wellness in a young woman's life because, let's face it, she's dealing with metastatic breast cancer. She needs that comfort at home. I think it's also incredibly important, particularly in a young woman who got diagnosed with that liver metastasis right at the time of her initial presentation of breast cancer, to not forget about the fact that she still needs a beautiful reconstruction. She's a young woman. She has a husband. She needs to walk around this planet. And, if we're going to be able to keep her alive for possibly many, many, many years into the future, she needs a body that she feels good in if we can achieve it for her. And so we can't lose sight of those issues when we're then dealing with the overarching effect that there is also a mortal threat to the cancer that this woman is facing. So we have to keep all of these in mind. So switching over to some of these survivorship priorities in metastatic breast cancer and how we manage them for our patients, I'm guessing many people on the phone have probably once upon a time picked up a Glamour magazine, and we all know there's that section in Glamour, that's the do's and don'ts. And so this is my metastatic young women's breast cancer do's and don'ts. And so, as we gain ongoing opportunity to keep our patients alive and well, it gets us into the territory of then what should the surveillance of that cancer look like, and how often should we be doing blood work? How often should we be doing tumor markers? How often should we be doing scans? And this is an area where I like to do what I call sharing the remote, or putting some of the control back into my patient's hands, because on chemotherapy, on clinical trials, on some of the upfront treatment that we offer these women, there's a lot of things that we sort of have to do, right? There's blood work that has to be done certain days. We think the scans should be done in a certain timeline. But if we are lucky enough to have a patient who is doing well and is now on a more maintenance form of therapy, there can be some opportunity to give them the control. And I think that's incredibly important, because one of the biggest problems of breast cancer, including metastatic breast cancer, is it takes away their sense of control, because it has taken away their control over their own life. And so I'll ask my patients, what would feel good to you? Do you want to do your next scan at 3 months, 4 months, 6 months? Things have been going well. The regimen is working. We can keep an eye on your blood work. We could always move the scans up if you're not feeling well or if there's a new concern. And I let them tell me what they want. Some of my patients will be fine pushing it out to 6 months, and some of my patients can never get there, even though they've been living well with metastatic breast cancer for 10 years. And that's okay. There's no right or wrong answer to this. There's a Goldilocks kind of moment to it. There's such a thing as scanning too frequently. You don't want to do it every month. There's such a thing as not scanning enough. We shouldn't be taking care of patients with metastatic breast cancer where we're not occasionally checking and making sure that the underlying disease is still in control, unless that's something you've discussed with them, because we have so many new available therapies to keep things under control. We don't want to wait till they're showing up with new signs or symptoms and disease that's gotten out of control. So some level of surveillance is important. And then you also have to listen to your patient. And the don't equivalent of that is to allow anxiety to override listening, and I mean both the patient's anxiety and your own anxiety. So many of our patients struggle with the fear of progression. And it's real because they don't know. They can't trust their body to keep them well. None of us can really trust our bodies, but when you've had a diagnosis of metastatic breast cancer, there's one very clear reason why you can't quite trust your body per se to guarantee your wellness. And so we have many patients who call, and they tend to be very anxious, and they can sometimes make our staff very frustrated or ourselves very frustrated with that level of anxiety. And we have to train our ears to hear past the anxiety and to hear what they are really telling us. So right now, we're in the middle of a pandemic. I don't know if you've noticed, but I certainly routinely am dealing with patients who are not feeling well, and that is driving up their anxiety. But when I speak with them and I listen to them, I think they're not feeling well because there's this little bit of a feeling like we're all going through life with a giant wet down blanket draped over our shoulders, right? There's nothing great about 2020 and the world we're living in the moment. And it compounds that to our patients who also have the uncertainty of a metastatic breast cancer diagnosis right now. And sometimes our patients just need to be reassured. Yeah, of course you're feeling a little bit more tired. You have metastatic breast cancer, you're working a full-time job, and now you're homeschooling 2 children remotely. So, that is normal. But for our anxious patients, you also have to be careful, because if they're telling you they're having nausea, or they're having headaches, or it's a clear focused symptom that could suggest maybe there is something new about their breast cancer, you cannot let the anxious patient not get heard if there's something that needs to be evaluated and tested. And that's where the art of managing metastatic breast cancer comes in. Another important don't is to demand control. These patients have to live with their disease for the rest of their life, and so they have the authority to decide, yes, I'm going to start treatment next Tuesday versus, nope, I'm going to do it the week after because I just need that extra week, or those sorts of things. So you have to allow them to have as much control as they can, and if they're starting to make decisions that you think could be bad for them, you just have to tell them. I was in clinic yesterday talking to a patient who is refusing a scan I really feel she needs. And so I said, look, at the end of the day, if you don't want to do the scan, that's fine. Here's what I will have on hand to deal with the symptoms you're telling me about without the scan. Here's what I will have on hand to possibly deal with depending on the results of your scan. What would you like to do? And at the end, she decided to go ahead and have the scan that I wanted her to have, but she also could have chosen not to. But I was clear with her how I was going to handle the moment in time, and I didn't get upset about the fact that she's refusing something I'm recommending. We have the opposite patients who want to demand things that we don't think make sense to do. We have patients who ask us for all sorts of strange blood work because they've gone off and seen a different provider in a different clinic. And so depending on what they're asking us for is whether or not we should say yes or no. If it's a relatively reasonable request and we'll understand how to interpret the results, well, then maybe it's okay to order that for them. It's important to let them know whether or not you're going to accept any authority to handle the results that you're given when you order that test, or if it is your expectation that they're just going to take it back to the person who suggested they have it and get information there. Shared decision-making amongst both Western clinicians and non-Western can get dicey, but at the end of the day, if that's what your patient feels they must do to best give themselves the chance of survival, you have to figure out how to navigate that.
Pardon me, doctor. I just want to give you a 2-minute warning. We're up.
Okay.
Over there.
Okay. Thanks. So, in general, there's a long game to this, and we have to just reassure our patients that no matter what, we will be there to help take care of them, and be as clear as specific as you can when you're asking them to do things, and never hesitate to say that you simply don't know when somebody is asking you a question and you don't know the answer, because we don't have all the answers about any form of cancer, particularly metastatic young women's breast cancer. So sorry, I started getting a little bit long-winded there. But I just wanted to spend what will be my last minute and a half with you talking about how you survive the care of our patients with metastatic breast cancer. And this comes from personal experience. You know, I think one of the important things that we deal with in life is that as care providers, we are most engaged in taking care of others, but the best way to do that is to take care of ourselves. And so long ago, a surgeon I worked with for many years reminded me that every day I have the choice to come to work and do what it is I currently do versus not. So many days I survived taking care of these very challenging and sad cases of young women's breast cancer by simply reminding myself that I don't necessarily have to do it again tomorrow. But yet, for some reason, that gives me the reassurance to wake up and believe that I can. It's super important to take care of yourselves, eat right, exercise, manage your own depression, anxiety, or whatever 2020 and the pandemic is bringing to you right now, as well as the long haul of having good connections with your friends and your family, making sure your own sexual functioning is where it needs to be. With our patients, it's important to have both connection and boundaries. We can't be without passion taking care of them, and we can't be without emotion taking care of them. But we can't get ourselves so wrapped up in their lives that when they pass away, we can't walk into the next patient's room and keep taking care of them. And that is a nuanced skill that we learn over time. And it's important to always share and connect with each other, reach out to resources like Living Beyond Breast Cancer or our own colleagues, and kind of share and commiserate both the pain and joy of taking care of these patients over the long haul. And in the last 10 seconds, I'll show you what I believe is hope through seeing progress. This article was published in December. It highlights an advance with a new drug that's come to market called tucatinib that's available for our patients. And I won't go through the data, but I'll just share with you that at the start of my career, there was about a 6-year survival with anyone diagnosed with HER2-positive breast cancer, even before it became metastatic. And now we are able to take care of women for years to decades, and tucatinib is a new drug that is particularly counteracting the issue of brain metastases for these young women and keeping them alive longer. And importantly, you know, here's an example of what that progress looks like. Women with brain metastases without this drug have 0% chance of not having progression within a month. And with this drug, a quarter of them are able to stay stable and doing well. And there's some recent publications on this. With that, I will leave off and accept your questions.
Okay, wonderful. Thank you so much, Dr. Borges, for this extremely informative presentation. I think in the interest of time, we'll just take one question for now. We did have some great questions from our audience, and due to time limitations, I am sorry that we will not be able to answer everybody. This is one I think is a particularly interesting one. I think it's a complex question, so I know it may take more time to fully do it justice. But do you have any additional thoughts on addressing the disparity between Black and Caucasian women in occurrence and survival?
Yes. So most importantly, for all of us in the field who are taking care of young Black women who get diagnosed with breast cancer, would be to encourage them to join research studies. One of the reasons we understand less about young women's breast cancer in Black women versus white women is the amount of data that's been published worldwide dominantly comes from the data involving white women. Now, there are some excellent research groups, particularly on the East Coast of the United States and in Chicago, where leaders in the field have made it their priority to look at the outcomes in young Black women. But there has been, pound for pound across all of breast cancer studied worldwide, far fewer Black women who have been willing to enroll in or been offered enrollment in translational research studies, the likes of which generated the data that I was showing you at the beginning of the talk. The other important feature is to some of the issues related to why Black women do worse might have to do with the fact that they are more likely to get a triple-negative breast cancer, but there are also some lifestyle factors that could be brought up in communities where Black women live, such as lactation being one of them, and use of birth control with OCPs being one of them. So those are things that could be brought into the young women's community before they ever become young women's breast cancer, and be stronger encouragement towards things like lactation in these women. But that's going to require big community shifts, because many of these women are not nursing, not because they don't want to, but because their life and their jobs and their existence doesn't afford them that opportunity as well. The more we can make sure that there is access to the supports that allow women to do these things as they're also working and building their careers in all communities of the United States is fundamentally incredibly important. And then there are great research programs right now drilling down on the differences of outcomes as far as treatment goes. And I think we will see an ongoing expansion of that. There's funding going into this issue now at a good rate. And so we hope to see that change in the next 10 years.
Great. Thank you so much, Dr. Borges, for that extremely important information. Really happy to get your perspective on that topic, as well as the many others that you covered. So on behalf of Living Beyond Breast Cancer, I would like to thank Dr. Borges for being with us and sharing her expertise. We are so grateful to have had you with us today, Dr. Borges, and we really appreciate the invaluable guidance you've provided to everybody who joined us. I'd like to also again thank the Centers for Disease Control and Prevention for their support of this program. And as I mentioned earlier, we will send you a link to the recording of today's webinar and the resources we highlighted within the next several days. And as a final reminder, you'll receive an evaluation link via email today. Please remember to complete it no later than September 30th. And again, for those of you who registered to receive nursing contact hours or social work CEUs, it is required that you complete the evaluation by September 30th, and then you'll receive your certificate via email by October 21st. Thank you for participating in today's program. We're grateful to you and your colleagues for providing care to so many people during these very difficult, unprecedented times. Please take good care and enjoy the rest of your day.